I see you out there. You've probably been Googling, does PRP actually even work for my knee pain? And it's what, like 11 o'clock at night? Here's my guess about why you're still not sure. You probably know someone who got it, and as a result, they felt like a completely different person. But you probably also know someone who got it, and they also spent a significant amount of money on it, and they felt basically nothing. And now they're in your ear and everybody else's ear telling them that PRP is nothing more than overpriced snake oil. Same treatment, completely opposite results, and nobody really took the time to explain why. Well, you know what? That's what this video is about. This is not a sales pitch. This is not a disclaimer. This is an honest clinical breakdown of why PRP works for some people and then does nothing for others. And I'm also going to talk about what the difference actually comes down to. I'll give you the short answer right now. It almost always comes down to how it was done. Not whether PRP works, it's how was it executed. And by the end of this video, you will know exactly what separates a confident clinic recommendation from an expensive coin flip. Before we get started, my name is Dr. Gayan Poovendran. I am a medical doctor and I specialize in sports and regenerative medicine. For the last 15 years, I've been helping thousands of golfers conquer their knee pain without having to resort to invasive surgery. Are you ready for this? All right, let's get into it. Actually, before we get into it, I've put together a free 5-minute warm-up guide that is specifically designed for golfers that have knee pain. I call it the Ready for Tee Off guide, and you can download it right now at readyforteeoff.com. So it's absolutely free. There are no strings attached. If you go get it and you come back, I promise I'll be right here. All right, welcome back. So here's the situation that I see like every single week and even today. A guy comes in who's, very successful. He takes care of himself in every single area of his life, and he tells me some version of this same story. He's had knee pain for 6 or 8 or 12 months. He finally went to go see a doctor, and he went through the gamut of non-surgical treatment. He did physical therapy, he did anti-inflammatory medicines, he got a cortisone shot. After the cortisone shot, he felt better for a few weeks, better than he's felt in a long time, but then the shot stopped working. So he goes back, and then maybe he got a second cortisone shot, or maybe somebody finally offered him a gel injection or hyaluronic acid. Sometimes it's called the rooster comb shot if you actually want to know where it comes from. And so that shot, maybe it helped a little bit, maybe it didn't. Either way, now he's at the end of his rope, and somebody is talking to him about whether he should do a surgery, or they're mentioning PRP. And here is where the conversation gets really interesting, because when his doctor brings it up, he doesn't really sound particularly confident about it, right? He says something along the lines of, well, yeah, you could try PRP, or I've had patients respond to it in the past. It wasn't really a recommendation, it was more like a suggestion. And when a physician is not confident in what they're recommending, that uncertainty transfers directly to the patient, right? So what does he do? Now he's online and he Googles it. And now he's finding conflicting information. Again, his friends are telling him it works, his other friends are telling him it's garbage. He keeps thinking about these two friends with the opposite results. So what does he do? Well, analysis paralysis means that he does nothing. Because why? Because nothing feels safer than spending a lot of money on something that nobody seems to be able to give him a real answer on whether it will work or not. And then, because he does nothing, the knee keeps getting worse. So that's the external problem, but here's what actually bothers me more about this whole situation. That patient, before he got to me, deserved a physician who could look him in the eye and tell him, here is why PRP is or is not the right answer for you, and here is what a well-executed protocol for PRP looks like. Here is what I expect to happen and why, not you could try it. An actual recommendation with clinical reasoning and thought behind it. You are a man who does not accept vague answers anywhere else in your life. You don't take them from your financial advisor, not from your accountant, your performance coach, not from the caddy that you're paying at the club. Unfortunately, you are in a medical system that was not designed to give you that answer. It was designed for throughput. You deserve a better conversation. I'm here, so let's talk about this. Does PRP actually work for knee pain? Here is the honest answer, yes. And the evidence is not ambiguous. There is a 2025 systematic review, and it looked at 18 randomized control trials that in all included about 2,000 patients. That study found clinically meaningful improvement in pain and function at 1, 3, 6, and 12 months. And this was not a small statistical blip. This was a clinically meaningful improvement, meaning the patients felt the difference in their daily lives for a full year. A 2024 analysis in the American Journal of Sports Medicine also found that PRP outperformed those hyaluronic acid injections, the gel shot, a rooster comb shot, with significantly higher rates of patients crossing what the research called the MCID. So that just means the minimum clinically important difference. That is the threshold where patients actually feel better. It is not just some statistical number on a paper. It is the patient saying, I feel better. Another 2023 network meta-analysis that compared every single major joint injection treatment for knees head-to-head, guess what it found? It found that PRP was at the top for pain and function control at 3 months, 6 months, and 12 months. Cortisone was at the very bottom of the ranking by 12 months. That last point really matters. Cortisone works really fast. It is a very powerful anti-inflammatory. The problem is what it costs you over time. There have been multiple studies, so this is not a secret anymore, that have documented accelerated cartilage damage on patients that have received multiple cortisone shots. I've seen this in my practice. Patients that were getting cortisone injections regularly, I could watch their x-rays get worse and worse and worse. The joint kept deteriorating, even though the pain was managed for a short period of time in between there. So for a man who is planning on playing golf for the next 20, 25, 30 years, look, that trade-off really deserves to be named clearly. And in most 7-minute appointments, unfortunately, it's not. So the evidence on PRP isn't really mixed, but it is directionally clear. And if your physician told you the evidence is weak, they may be reading some older literature, or they're looking at literature that included very poorly executed protocols, which this brings us to the part that actually explains the difference between your two friends. Here is why one person can get PRP and feel like a new person, and another person can get PRP and feel absolutely nothing. The most simple part of this is PRP has a dose response curve, just like any other medicine. When you get a headache, you don't just nibble a little piece of Tylenol, right? You take a dose that you're supposed to take. Just like that, with PRP, there is a minimum effective dose. Below that dose, the treatment probably doesn't move the needle at all. Above it though, the outcomes are real, they're durable, and they're pretty consistent. And that's what you want. A 2024 study in the journal Cartilage identified that the minimum effective threshold, and here's what that data showed. When you're comparing research studies on PRP, the studies that found that PRP works delivered roughly 2.5 times more platelets than the studies that found that it didn't. So I'm going to throw out some numbers for you that you may have no reference for, but just kind of listen to them. The studies that had poor outcomes with PRP, they ended up giving about 2 billion platelets per injection. That sounds like a lot, right? But let's look at this next step. The results that started to show good results, 5.5 billion platelets per injection. Now, the best results though, those were delivering somewhere between 8 and 10 billion platelets per injection. So look at that. Bad result with 2 billion, excellent result somewhere between 8 and 10. These are the same treatment name on the chart, right? Everybody is getting PRP, but they're completely different biological deliveries and they're completely different outcomes. Now, here's the uncomfortable truth about that though. A low dose, poorly PRP can still work sometimes, right? I'm sure that not everybody that gets better has gotten a really good PRP, but for some patients, that's not a clinical outcome, it's a coin flip. And there is a meaningful difference between a physician who can tell you that some patients respond to PRP and a physician like me who says, here's the dose, here's the preparation, here is why this is the right protocol for your specific knee, and here is what I expect to happen. One of those is a recommendation. The other is a checkbox on the way to surgery or something else, right? Here's another really interesting thing. I've had PRP done on my own knees. I have some early wear and tear, something called chondromalacia in both of my knees, and I have a meniscus issue in one of them. I did not go into that treatment hoping that it might work. I went in knowing exactly what was going into my joint, why it was formulated the way it was, and what outcome I was targeting. That, my friends, is what a properly executed protocol feels like from the inside. And here's what it looks like from the outside. The blood draw, well, the volume is calculated, it's not standardized. It is based on your baseline platelet count, the number of structures that we're treating, and the severity of the issue that needs to be targeted. A patient that has a higher baseline platelet count, we need to take less blood in order to hit that therapeutic threshold of 5.5 billion platelets. A patient that has a lower baseline, we are going to need to take more blood from them. But that decision is made before anybody touches the kit, right? Then the PRP is quantified. I take the PRP sample and I run it through a hematology analyzer. This is the same technology that's used in a hospital lab, and I get actual numbers, the total number of platelets that are in that syringe. I can also tell them how many times over their baseline it is. I show that number to the patients. I don't give them a range. I don't say that this manufacturer says that we're going to give you a 5 or 6 or 7x PRP, but I actually give them a number from calculations, because if we are not measuring what we are making, we're not managing the outcome, we're guessing, and I hate guessing. We also have to customize the cellular composition based on what the tissue actually needs. The cells that we include and the ones that we leave out, they change the biological signal that's being delivered to the joint. Think of it as the difference between sending a repair crew with general instructions versus hiring a specialized team with a specific job. This PRP is built for your knee. It is not built for a generic protocol applied to whoever walked or limped into the office then. And then the injection is performed under ultrasound guidance, live imaging, confirmed needle placement before a single drop is delivered. Well, you know what? There is a version of this conversation that I've had with very confident orthopedic surgeons. They do not think that the use of ultrasound guidance for injections into the knee is necessary. They say, I've been doing this for 20 years. I know the knee. I don't need it. Well, the literature disagrees. Studies show that experienced orthopedic surgeons, these are the people who know the knee anatomy better than virtually anyone else, the people that operate inside that joint for a living, they miss the target on knee injections without ultrasound approximately 30% of the time. 3 out of 10 times they're not in the joint. And these aren't residents, these aren't trainees, these aren't medical students, these are attending surgeons with decades of experience. Let's take that one step further. Think about this. If that is the miss rate for the most procedurally experienced person in the room, the one who literally cuts knees open for a living, I want you to think very carefully about what the actually looks like when the person that's doing your PRP injection has significantly less procedural experience with that specific joint, and they also have no imaging to confirm where they are. Ultrasound guidance brings intra-articular joint injections. It brings that accuracy up to 99%, probably above 99%. That is not a luxury. That is the only standard that makes sense when you are delivering a precision biologic treatment that took careful preparation, costs real money, and needs to land in the right place to do its job. Look, I am a nerdy physician and I probably think about this stuff way more than is healthy for a normal socialite. My wife will probably agree. But when it's my knee on the table, and it has been, as I just said, I want every one of those details handled correctly. And I personally think that your knee deserves the same attention and thought that I give my own knee. So here is the one thing I want you to do differently after watching this video. Before you let anyone inject PRP into your knee, ask 3 questions. This is not to quiz the physician, but this is to find out for yourself whether they are building a protocol for your knee or they're just running a standard protocol procedure on it. Question number 1, how do you determine how much blood to draw? The wrong answer is, well, we always take 1 syringe or we always take however many cc's. The right answer involves a conversation about baseline platelet count, structures being treated, the severity of the pathology, and how many platelets they want to have. A standard answer will just tell you that they are running a standard protocol. Question number 2, do you quantify the PRP before you inject it? Are you gonna give me an actual platelet count or is it just gonna be an estimate? What dose are you aiming for in my procedure? A physician measuring that number is thinking about that and they are managing your outcome. A physician who isn't thinking about those is just, again, managing a generic protocol that's not made for you. Question number 3, is this injection performed under ultrasound guidance with confirmed needle placement before anything is delivered? Again, that is not a luxury. That can be the difference between a precision treatment and a very expensive guess. Now, if they answer all 3 confidently, you are in the right room. But if they can't, respectfully, please keep looking. But here is what changes when those 3 things are true. The treatment stops being a coin flip. You are not hoping PRP works for you in the way that it worked for your friend. You are now walking into a protocol that was calibrated for your biology, calibrated for your pathology, and calibrated for your knee. with a physician who can tell you why they expect it to work and what they are looking for at reassessment. That is the difference between you could try PRP and an actual strong clinical recommendation. And if you don't do this, if you accept the, well, you could try it as enough clinical reasoning, well, here's what can happen. You may get lucky and the injection may work. A poorly prepared PRP may still move the needle, but you might not. And if it doesn't work, you will walk away more skeptical than you were when it started. And then the next conversation will be about surgery. Not because surgery was always inevitable, but because the right conversation never happened. Now look, this is not a scare tactic. Here's how I think about a knee that has been through the cortisone carousel, the failed gel injection, and years of progressive wear. It doesn't just need a treatment, it needs a rebuild. And not a surgical rebuild, a biological one. Tissue that has gone chronic needs to be reactivated before it can heal. Inflammation that has become the baseline needs to be addressed at the cellular level, not just suppressed at the surface. And the joint environment itself needs to be optimized so that when that regenerative signal arrives, the biology is ready to act on it. That is not just one injection, that is a coordinated protocol. In my practice, PRP may be the centerpiece, but I build around it. I combine it with shockwave therapy or ESWT, which basically means we have a handheld device that delivers focused sound wave energy directly into damaged tissue. There's no needles, there's no surgery, there's no downtime. This chronic tissue is that tissue that has essentially stopped trying to heal on its own. The repair signal faded and the body moved on. Shockwave therapy helps restart that signal. It doesn't just treat the area, it actually reactivates it. So the PRP ends up not arriving into a stalled environment or a stagnant pond. It arrives into tissue that has been primed and is ready to respond. For patients who are not yet ready for an injection or those who want to take a progressive first step, well then sure, BPC 157 and shockwave together can be a meaningful starting point. The healing process begins before we even ever pick up a needle. This is what separates regenerative medicine from a procedure. A procedure treats the symptoms. A protocol addresses the biology underneath it. The point is this. If your treatment plan is a single injection or a series of injections and then just a follow-up appointment in 6 weeks, you're not really getting regenerative medicine, you're getting a PRP injection, you're getting a procedure. Those are not the same thing. So you came here wanting a straight answer, so here it is. Yes, PRP works for knee pain. Not necessarily the standardized, underdosed, blind injection version, but the real version that is built for your knee, measured before it goes in, placed exactly where the tissue needs it, and by a physician who can tell you why they expect it to work. That version works a lot more than it doesn't, and the evidence says so. I have seen it in my patients every single week for the last 15 years. I have felt it in my own knees. The difference between your two friends is not luck, it is execution. And now you know what to ask for, so go get it. When you contact a physician about PRP, bring those 3 questions with you and listen carefully to how the physician answers them. How do they determine blood volume? How do they quantify the platelet count before injecting? Is the injection performed under ultrasound guidance? Those questions will tell you whether you are in the right room or not. A proper evaluation also means a full history, current imaging, and a physical exam that goes beyond a 3-minute, does it hurt here? How about here? What about here? The right treatment starts with the right diagnosis. And that's where this conversation begins. And don't forget, before your very next round, grab that free Ready for Tee-Off warm-up guide at readyforteeoff.com. Again, it's 5 minutes on your phone right before you tee off. Your knee will feel the difference from the first hole. And if this video gave you a straight answer that you've been looking for, send it to one of the guys in your group. I promise that he's probably up at 11 o'clock also Googling the same thing. I'm Dr. Gayan Poovendran. Now you know what most golfers never find out. I will see you pain-free next time on the fairway.